I would like to call Professor Sandeep Gupta, sir. He's a senior urologist and a renal transfer surgeon attached to ILS Hospital, Charnock Hospital, and Manipal groups of hospital.
I think my introduction is not important. We'll go to the next slide because the main speaker is waiting for us. So I would like to call upon Dr. Sanjay Pandey from Kokilaben Ambani Hospital, Mumbai. Sir has come specially for this session from Mumbai all the way on our request. I'll just give a brief introduction about Sir. Sir is heading the Andrology and Reconstructive Urology department in Kokilaben Ambani Hospital since 2009. He is also into robotic urology and gender reassignment surgeries. Sir has underwent advanced training in Italy, Belgrade and Korea also. Sir's interests are in Botox, Peyronie's disease, MRKH, incontinence, prosthetics, etc. And he has multidisciplinary clinics in the hospital on gender dysphoria clinic and nocturia enuresis clinic. Please, sir, I welcome you. Dr. Sanjay Pandey, sir will be giving the talk for today. Thank you, sir.
Respected chief guests, sir. Respected members of this august body. The organizers of this wonderful conference on a very historic day, where I too join in solemn protest to what is sadly happening in this part of the world. Thank you for organizing your inaugural Congress and having such a deep immersion meeting. It was wonderful to look at the last workshop only because of time constraints. Pardon my voice for a while, but I'll pick it up. Thank you for thinking out of the box, Dr. Arvind Oza, Dr. Sandeep, respected chairpersons. We're going to take it forward in a very deep immersion and a very quick slot because each of you is a urologist. You treat UTI, you treat incontinence, you treat stones, you treat prostates. And we as urologists would see tip of the iceberg, which you do, probably you send to us. The Bengal Urology Society is very close to my heart. Can I Bangla bolte pari ho jane ami barambar ekhane aste chai. I belong to Lucknow. I was born in Rourkela. I trained in CMC Vellore and JIPMO Pondicherry and now working in Maharashtra. It means that I'm doing a national integration of North, East, South and West. So thank you, respected chairperson, sir. You said every day is a new learning and I learned a lot on the last session around. Take you forward because my left eye is on the clock. I'm watching what is happening for us in a conference around. We all attempt to do A to Z. I'm doing an A to Z in a very quick shot. So for you as urologists in this audience, a little bit of andrology, which will help you to take it forward because this is a very deep immersion meeting. I made some changes on the slides that you look forward to. So my respects to all of you and tips and tricks in a very practical case-based presentation. I carry greetings from Kokilaben Ambani Hospital, where I worked for the last 16 years as a head. I got promoted as a director last week, which was not a major sunshine, but I wish sunshine to all of you, wish sunshine to your families, and wish pink of health to you and your patients. And God bless us all in medical fraternity and beyond. Friends, the good news is you all are pilots in North Kolkata. You all run the show here in the whole of Kolkata. The bad news is I've given myself 45 minutes time and the time will fly. You all are magicians, you do magic every day and that is something which you make. I'm going to talk about magic between the thighs. I do susu and sex. It's a wrong time for that kind of a thing happening around, but when we look at agony of individuals who are couples and men who go through graceful aging and go through trouble and trauma, I think they need help, and that help is given best by you as physicians who holistically look at everything, all the organs compared to we being partners with you in the pelvis. So friends, what got us here will not get us there is what was our chief gets very strong language around. As my wall fills up over the last 24 years when I started urology in CMC Vellore and around, you would see a lot of them marked in red. It's all about the topic that you've chosen. And when I go back home, I will actually put this on my other wall. That means all of the conferences, those 295 conferences in 224 years have been respected by putting them back on the wall. It reminds me that there is so much of things to learn around and learn. So I motivate myself every day to the motivators I know. These are all leaders in urology other than the big B who invites me to the KBC to give some speeches on organ donation alternate years on Dhanteras Day. These are teachers, the sexologist Dr. Prakash Kothari, my teacher Dr. Ganesh Gopalakrishnan, Dr. Sunil Shroff, the father of botulinum toxin, Dr. Michael Chancellor, the teacher who taught me gender reassignment, called Dr. Miroslav Djordjevic, that's father of modern urethroplasty, with whom I did an operative workshop from Italy, Professor Babagli, and the whole world around. So when I get motivated with such a full house here, having great workshop in the last 3 hours, I think it's time to connect AAPONCON to the society in North Kolkata. I gather that in men's health too, apart from the wonderful work that we do as physicians across, the headline should change, and from them saying that I love my urologist for everything, they should say I love my doctor, who is actually the boulder and probably taker of my health around. So friends, as I unmask the subject is quite deep. It comes opportunistic that very few topics evoke so much of anxiety and pleasure, pain and hope in present times, discussion and silence as erotic possibility of our bodies. We hardly discuss. Patients don't speak up on their agonies around, but the modern patient has got huge expectations from you. As somebody said, the sugar should come down in hours, that's what the expectation is. Similarly, the expectation is when Dr. Sandeep Gupta or my colleagues in Bengal Urology do a TURP, the patient still is unhappy. Whereas he is actually passing from here to Islamabad. So it's a modern patient who is going to bend you like Beckham. And be prepared that all modern patients and relatives are going to make it very challenging, apart from what is going on in today's world. Friends, we are deep immersion in the next 40 minutes to look into what does a needy man seek. A needy man is probably a part of the couple phenomena, and he's seeking about hard and long-lasting erections. He seeks to be Mr. Consistent, capable of firing his gun every time. He should be capable and dependable to the couple phenomena that he should be practicing in the bed. He should be able to satisfy himself, his partner. He should be having a self-confidence, and the commonest cause of erectile dysfunction in the world is anxiety. Men from a wafer-thin incapability one day make it a wall with their partners because they think that they cannot perform. So that's a huge amount of work, and therefore you and I, as teachers, as leaders, would counsel these patients again and again, because the erotic possibilities of this new and learned has to be taken forward too. I'm looking at improvement of quality of life, and therefore I carry these two important books on the slide, which are from Atul Gawande, one of the doctors from India who's done great in the United States. I behoove all of you to read these two books, and these are medical books of the kind that Atul Gawande had read. So in other words, under Hippocratic Oath, we derive inspiration from doing better without complication. That's what all of you do. That means we have everything better without complications. But when I go directly into the subject, men want to have longer, bigger, better, and that's how all men want. The male erection cycle is a huge cycle. It starts from erotic feeling, sensations, to the whole pattern of flaccidity, and then the latent phase, and then the erection, then the deutermiscence. Imagine the story, what happens around. And there are many men in their 40s to 70s who need treatment. Who are they? 50% of men in the world right now, from the age of 40 to 70, have got erectile dysfunction, the whole comprehensive picture of anything that you can imagine. Imagine this. Women have got their menstrual periods, and at a point in time the menstrual period stops. She knows she has reached a climax. Men are smart enough, and they don't believe that they are gracefully aging. My black hairs are turning grey, and I don't believe that I can have a prostate issue, I can have erectile dysfunction. And men continue to smart enough, and one fine day actually fall down. So all men need treatment, and men who need treatment are really needy. Because in Japanese proverb, it is said that the prime of your life does not come twice. So all of you who are today going to celebrate your birthday tomorrow by cutting a cake, remember that you will actually turn 1 year older, but you will clap for it. And that's what is erectile dysfunction about. Inability to achieve, maintain or sustain an erection firm enough for a coitus or penetration that may result from huge amount of changes happening around the neurobiology, the psychological, neurological, hormonal, arterial, cavernosal impairment from a combination of one or more factors which happens to men in the stress of life that they lead today, is all about a complex medical condition, which today has got different connotations. With my chairpersons as cardiologists, neurologists and diabetologists, know that it's more of a metabolic disease today. And unfortunately, the prevalence is tremendously rising. It's just rising like any other thing. Like the petrol price is rising here and we can't do anything. We can't do much to erectile dysfunction. And therefore, the happenings of good bedroom story, which was always very good and pleasurable and capable enough, becomes a dream for the good bedroom story for couples of the same age and beyond. Men want to stay younger all their lives, and therefore they come and request. Therefore, the motto today in this next 40 minutes is about looking at impossible to possible, finally treatable, and finally doable to curable. And yes, we can together when we look at the good news that India prevails. Back at the Kokilaben Hospital 16 years ago, I did follow this Vikram Sarabhai's very important quote. Take this quote forward. He who can listen to the music in the midst of noise can actually achieve some things around. So apart from doing urology, I went deep into immersion into reconstructive and robotic urology. Andrology and female urology is very close to my heart. So I may not be in a medical college, but I love teaching around, and I love reincarnating into requirement of a patient to whom you should be fresh All the time you see them in morning, evening, night, because their needs are important. That's why you chose to become a doctor. Treating their agony of untouched issues which they don't speak out. For example, women never speak of incontinence. They wear diapers. They think it's a part of aging. Men never speak of erectile dysfunction till you put them on the bed, examine the prostate and say, "Sab kuch theek hai bed pe," and he will open up and say, "Doctor never asked me before, and now when he asked me, I'm telling you." So are we looking at life-saving, life-extending, life-changing and life-modifying treatment for a lot of individuals who actually go through agony of quality of life diseases. Incontinence and impotence is completely in the backyard. Nobody discusses till a point in time. And therefore, in this very august audience at the AAPONCON today, all of you who deal with men's health, which is what you deal with, it is important for us to look at the wake-up call where the dark clouds can go away and there can be a lot of sunshine for couples around. Let me just put you some data to make it more of a workshop as I go to some cases to complete it. Erectile dysfunction is about happiness. Happiness is not about what we have in the bank and back and home. It's all internal, quite an innate and a non-negotiable feeling. Look at this important aspect. 1,400 men in the age group of 18 to 59, the prime of life. ED was significantly associated with low satisfaction, low emotional satisfaction, low generalized happiness. They are really not confident, and that's the commonest cause of issues around. And therefore, Pfizer did a major study. In 28 countries, 26,000 men answered this 61-item questionnaire. The two important questions are, how important is sex to your life overall? Something which is quite internal, we'll never speak on stages. And do you think your doctor should ask? And look at the answers that they gave around. The global study said that 53% said sex is important in that major age group. 15% had concerned sex life, less than 7% had asked by doctors, and 50% said doctors should ask. So doctors should ask beyond what? For example, we are guilty of not asking women in their 50s to 80s that do you leak urine? Sadly, the women's phenomena is that they leak urine, they cough, run, jump and even laugh, and they leak urine, and as clinicians we never ask them. They're wearing diapers all the time. That's what happened to our mothers and grandmothers around, because that's a natural phenomena of the female pelvic floor. So doctors should ask, and that is how if we ask around we pick up a lot of things. Friends, we're going back to the topic of erectile dysfunction or men's andrological issues on the organ, where you can predominantly as a clinician in few minutes of talking pick up whether it's an acute psychogenic issue. He's good with a partner called the secretary, but bad with his own wife as a partner. He is having a diabetes and smoking and metabolic syndrome, so he's getting into the organic kind of erectile dysfunction, which is progressive, compared to a psychogenic, which is hugely acute onset phenomena for some phenomena which happened, which he failed around, and things pick up. He also has a psychological aspect to the entire story. So friends, when we look at this and we look at the inventory, which is all everywhere around, we get to know that these individuals are at what level. We score people around. All the scoring patterns of IPSS symptom score on prostates or IEF gives us an idea about what. So when we look at this aspect, and we'll go to the cases soon, bottom line is teamwork. We is stronger than I. I alone of all the eyes in this august audience cannot do much. But if we join all the eyes together, I think we do wonders as being partners in medical fraternity. So tips could be completely worked up cases, consented well, they understand, and the realistic expectations. Today's expectations are sky high beyond 120%. Bring them down to 75%. Tell them this is what medical fraternity can follow you. Tricks are about great counseling, and counseling is never one session. We counsel patients again and again and again, and that's how the journey of meeting them again. And I think it breaks the ice. Conservative treatments, medical and surgical, and the state-of-art therapies by the kind of guidelines, approaches that our teachers teach from this august stages around. The trials are about evolution and the right approach to right individual. That means we should be armed to the teeth to be able to treat ABCD and XYZ also. So whatever the patient comes up, we should be able to do it. The triumphs are about the steep climb and the audits that we have for our own results. We should not be blowing about one case, but umpteens of them and doing better and better. The technique that we do to achieve a 95% success rate. And therefore techniques are all about armed as A to Z in andrology. The tribulations or difficulties of the disease itself, which is a challenge. The same man will be different a day, week and a decade later. Let's accept complications can happen by our work and redeem it back. So as I said, we would leave it to the practitioners of the art, like the diabetologist decided to give what insulin levels, and we touched the first of its phenomena called sildenafil. The drug was actually made for cardiac issues, and in Sandwich in England in 1984, men did not return back in the clinical trial the medicine that they were given. What happened to the heart, nobody knew, but each developed a wonderful erection during the study, and that's how the drug was changed over in the phase 2 trials from what could be a cardiac drug to now being sold as the highest drug in the history of mankind in men's health, called the Viagra. So sildenafil is a great drug. It addresses both the functional and the emotional domains of erectile dysfunction and the ejaculative dysfunction. In other words, harder erections, consistent efficacy and durability, and translating this into patient partner confidence satisfaction is what you and I aim. And men do deserve, and you treat such patients. You give them 50 milligrams as and when required, And Dr. Sandeep and I know that just giving 50 milligram tablet before sexual activity does not work. You're already so anxious. If you stand outside the examination hall and start studying, you will fail the exam. You got to prepare every day of your life. So, in other words, what we do actually is we probably give them an induction dose and then we put them on a maintenance dose, which could be an SOS. But giving them one tablet once in a week, once in a month, nobody would pass the exam around. So remember, sildenafil 50 or 100 milligram never works. They say the medicine is bad. The medicine is the best in the mankind. In other words, we need to use the right approach to right individual. When we look at the unmet needs are beyond it, because the prescription patterns have been such on this drug across the world, including our colleague physicians, including us as urologists and andrologists. The unmet needs in erectile dysfunction are the drug has actually failed, only because we did not use the right approach. 30 to 35% patients fail to respond, only because they are being given 20 minutes, half an hour before a sexual activity, on which he has to go and perform on the stage as strong as this, which is a woman waiting for him. 62% prescriptions renewal rate at 3 to 4 months on follow-up. So as the follow-ups happen, a lot of people don't come back. They probably lose it out. And prescription rates drop to around 30% by 6 to 12 months. In other words, the prescriptions never drop for hypertension and diabetes. So why drop for this, which is the lifelong continued phenomenon? Because it covers all the aspects and domains. Don't take Viagra as a drug now which only treats erectile dysfunction. It is holistically something which improves your vascular health in the pelvis. It has been studied very, very strongly. 25 milligrams of Viagra or sildenafil is being used by a lot of people in the pelvic health, including the tadalafil group. And I think more of you use a very high supraphysiological doses for a urologist in your pulmonary arterial hypertension. So the drug has been there. The drug has been effective. It has been effective in individuals who have got diabetes, who are antihypertensives and peripheral vascular diseases, and failing erections completely. All these are naughty culprits which actually bring about erectile dysfunction as a parallel phenomena. So friends, when you look at this and you move forward, you understand that individuals with placebo do nothing, but with sildenafil at different dosages do well. So we can't eat a spoon of rice and do well. We need a bowl of rice. The right dose, that's what you practice. So 25 milligram does this, 50 milligram is optimal, 100 does good for somebody. The dosage is what a clinician decides, it's not a patient. Sadly, many of these drugs are actually off the counter across this part of the world, and our patients pick it up. The patient response is amazing in all kinds of diseases. Please look into all kinds of aspects, organic, psychogenic, severe, and the timings. These are very effective drugs. So for you, the Indian Viagras available as sildenafil are effective drugs at all age group, because it has got 25 milligram regeneration pattern of the pelvic vascular health and beyond it. Friends, there are reasons why people don't continue this drug. That's an important slide. I just copied it from somewhere, which sees that people are unwilling to depend on the medication for sexual intercourse. Men are always going to be men. We know that well. Spontaneous recovery without PDE5. People think, I will just recover. My gray hairs will turn black. I'll get younger, which will never happen. People are worried about cost. I mean, cost for your own body is all that you are earning money for. So spend money on your own body rather than probably looking at it in the bank balances around. Concerns about side effects. That's how it is. I think we use a wrong word called side effect in medical science. It is an effect which is unwanted. So if you don't want the effect, probably stop the dose, cut down the dose, go to your physician. But the side effect word, even Baba Ramdev is actually hitting allopathy yesterday. Lack of emotional readiness for restoration of sexual activity after long-term abstinence, and therefore people have that confidence loss. Psychological burden of scheduled sexual intercourse, and that's no scheduling required. You should be ready for an exam. You should come tonight on Mahavir Jayanti or on Buddha Purnima or on any day. You should be capable of performing as required. Unwilling to have sexual intercourse, discontinuation since it was more important to treat other diseases rather than quality of life, and partner unpreparedness due to long. So aspects where people stop medicines around is amazing. But there are people who actually don't respond. There are people who don't respond to the drug, and that's sad, which means severe erectile dysfunction and presentation, diabetic for last 20 years, a microangiopathy and end-stage vascular disease in the penis. Along with that, smoking and causing severe microangiopathy. People will not respond. Giving them a Viagra who is 20 years of chain smoker and has a diabetes for 20 years. Don't give them that. Doesn't work. It just doesn't work. Worsening of endothelial dysfunction and progression of penile atherosclerosis in all the metabolic syndrome which my clinician colleagues in this audience treat. Erectile dysfunction of radical prostatectomy. The nerves have been damaged by me. I do a robotic radical prostatectomy where I do a nerve sparing for young men or for a low-grade disease. Otherwise, you damage the nerves, you only need a penile prosthesis. Unrecognized hypogonadism. We're busy hitting this, but we know that the hormones are gone, and therefore nothing will work because the neurobiology of his early morning erections are gone as a result of the vascular issues or the hormone issues. Inadequate patient education and the incorrect drug capability usages around. Development of tachyphylaxis, psychological factors, a huge factor. It should be up there, and missed out hypogonadism. So friends, just to give you an idea that I'm trying to wake you up that this is a phenomena where we go deep into it, and therefore we stronger than I. My colleagues in Kolkata do awesome andrology, including Sandeep and people around, I look forward to them getting a chance to be treating and curing patients. Treatment is all that we can do. But can we cure somebody? Does paracetamol continue to keep fever all the time? No. Paracetamol is supposed to clear the fever off. Similarly, sildenafil, PDE5 or the therapy that you and I give should treat people around. Let's go to new stuff around. Look at this gentleman, young with its own accompaniments. He's only 44 years young. He looks young. Capable in all spheres of life. He has got a Ferrari car in his pocket, but he is refractory failure in the bed. Also remember that when he has to pass urine, he can't find his organ. It is all hiding somewhere deep inside. So he is almost incontinent. Libido is going down. Early morning erections are very poor. His shaft is shrinking for reasons visible to you. And he's got medical comorbids, which is a modern quality of life that people lead. He's got obesity, the kind of central adiposity you see, the metabolic syndrome. So such kind of people have got late onset hypogonadism. They believe it or not, their hormones are going away. They don't need to stop their menstrual periods. It's progressively going to go away with an add-on accompaniment that he has. And such patients are into the fitting domain called as male andropause or late onset hypogonadism. That's a term which we use around. They've got sexual issues they have somehow managed. They've got non-sexual issues which they have. So this is all there, but they will never speak around. They come for incontinence of urine or obstructive voiding at 40s, 50s, and you ask a question, you examine them, you know that this man is unfortunately not capable now. And he can be reversed by you and me. The testosterone replacement therapy for late onset hypogonadism is the therapy that has come to stay and is going to happen around. Obviously, the practitioners of the art have to look into it. So his sexual complaints and non-sexual is known to us and is visible to us. So late onset hypogonadism is for all those men who have chronic disease states like the diabetes, the metabolic syndrome, the long-standing hypertension, pelvic health issues, etc. in the influence of advancing age. It makes it difficult to separate this influence from the comorbidities, and high BMI, central adiposities, metabolic syndrome are very closely associated with late onset hypogonadism. That means if people in 40s of the profile I showed you as a man doesn't get early morning erections, he has got an central adiposities, hypercholesterolemia, etc., he is in trouble. So I have a take home on this important aspect is men who are busy eating burgers and KFCs and McBurgers actually go through this, who have sedentary lifestyles, sitting and probably busy on WhatsApp or their work to earn money for the bank balance. It needs a very high index of suspicion. Men would never complain. Men never complain of things which are very slow and progressive, millimeter by millimeter. It's worth scoring them by an Adams scale, by MMS scale, exclude other causes of testosterone deficiency, must have symptoms of low testosterone. Testosterone should always be tested in the morning, preferably at the empty stomach, and then look at, if required, take it forward. So in other words, it is important for us to look at, there are only two subjects in medicine. One is urology and one is ENT. They've got similarities. That means half the organs are inside the body, half the organs are outside the body. In ENT, some organs are inside the body, some outside the body. Whatever you treat outside the body, patient is very capable, he understands. For example, if I do a circumcision, patient knows everything. A good or a bad circumcision. If I do an nephrectomy, patient doesn't know anything. So in urology or genitourinary surgery, half the organs are inside the body, half are outside the body. When you treat the organs of testis and scrotum and penis, you know the patient is too much up there. When you treat the kidneys and adrenals and bladder, nobody knows what you're doing around. So remember, a modern patient is looking into these two subjects, ENT and urology, with a lot of pinch of salt. Dial U for urology or dial A for andrology has a lot of expectations that people have. Under the undergarments, they are actually anxious and capable. And a lot of you practice endocrinology out here. This is not a very uncommon phenomenon to me because I sadly happen to be a referral center for this. A very young man, 24, now wakes up that he has got hard but incapable erections. Why incapable? They're hard enough, but they're hiding in the moorings of the pubic bone. His height is good, his hormone profile is as good as yours and mine, but he has a short and a non-serviceable shaft. When he was a young boy, he could pass urine well. When he is grown up, he's still passing urine well. But all of us as men here know that the organ becomes capable, and adolescence, we can also perform sexually. He's an incapable guy. So what is his future? Extremely bleak future. He's anxious for a shaft enlargement. Sadly, the phalloplasty is not happening in this country, and I'm right now inundated 10 days a week for all kinds of men whose penis is short, absent, etc. Look at somebody who had a carcinoma penis at the age of 33. Young men, non-circumcised, can get carcinoma penis. It's only the Jews and Muslims who won't get because of the non-irritation of the tip. But if this man got a partial amputation by some urologist somewhere around, what he has left over is a residual micro, mini, ultra mini shaft which is buried inside. How does he perform anything? So these are the kind of men looking at, and I'll end up doing something called as phalloplasty, creating a new organ. He feels confident. He may use the organ or not is a different issue, but he gets his organ, he gets his erection, he gets his urethra, and that's again a man-made phenomena or a God-made phenomena on men who have got endocrine issues around. So that's where we have to probably mince this and probably take it forward. So these are all patients who could get a new organ altogether. They could pass urine, they could be successful, and taking it forward. Friends, we're moving on to another subject, which is a very, very important and agonizing subject. Allow me to present this in next 2 minutes. Epidemiologically, this is an amazing disease. I call it as 3 P's. The 4th P is called as Peyronie's disease. So Peyronie's disease comes with a palpable plaque, a painful erection, and a penile curvature. In the prime of life, in 40s, 30s, 50s, men go through the agony, and this is probably getting more and more. I see diabetics suffering more, but the cause is not, the cause is more of a micro trauma to the penis in erect states, where the prevalence I see in the last 25 years is rising. Let's take an index case. Have a look at him. This gentleman is sadly another gentleman. He's going through this organ and the kind of curvature and torque he has when he gets his best erection. So his best erection is his worst curvature. Have a look at him. 43 years young in the prime of life, progressive debility when in the bed. Otherwise he can pass urine, he can direct his stream, satisfactory erection, but just incapable since last few months and now completely impossible. What does it mean? He had normal and satisfactory erections, then progressive failing in the bed because there's a progressive change and curvature in the penis as a result of the plaque developing, which is bringing about a corporal change altogether. And finally, he continued to adjust his postures to perform sexually, and now the couple just cannot be done. That means they can't penetrate. He has got a dorsolateral body, which means that he's failing in the bed. Give me a few more minutes, I'll wrap it up. So he's failing in the bed with that kind of an erection, which is a phenomena that he goes through. In other words, management of Peyronie's can never be medical. We don't treat Peyronie's disease. We treat all diseases in the world. We don't treat Peyronie's disease. We treat the ill effects of Peyronie's disease, and that is what we treat. We also don't treat the plaque. We can't melt the plaque. There's no drug other than verapamil gel which can melt the plaque, but that doesn't happen. Which means the pain, discomfort, cordy, indentation, hourglass, loss of length, erectile dysfunctions are what treated. And sadly, all of them are surgical approaches. We have to operate them and take it forward. So when there's a stable, mature disease from the acute disease, we go ahead, operate, straighten them up so that they can pass urine in a straight queue and then take it forward. So I will not go to the procedure. This is completely beyond our colleagues in the medical science. But this is what we do a penile disassembly and make the penis as straight as possible. So take home message here is Peyronie's is not uncommon. Nothing is uncommon. It's just that we don't see it happening around. And I am hammered with these kind of debilitating diseases which come in around. So to meet the realistic expectation and make them capable in the prime of life, not then 70s and 80s, but 30s, 40s and 50s, men, look at it. They are in agony. They probably search me on the YouTube and come over. And there's no ideal procedure. I should be prepared. I should be prepared with the A to Z. I have to disassemble the penis like a book, then assemble it back after the repair. There was a time 24 years ago I did only 1 in a year. Now I do few per week, and this challenge goes on. Friend, this is about acquired disease. But look at men who have just got adolescence. 18 to 25 years young man says my penis is completely curved. This is called congenital penile curvature, and we would take it as psychological. Look at the erections. They are completely bent. How do they perform? And they are in agony from their adolescence. So 18 to 25 years come with that kind of issue where you have to placate and make it straight. And look at those whom we treated for hypospadias. Multiple hypospadias therapies. The penis are all bent around. Everybody is in a rush in a pediatric age group. Jaldi se surgery kar do, hypospadias ko theek kar do, bring the urethra to a tip. The kind of fistulas, the kind of surgeries, the kind of stuff happen around brings a post-hypospadia stage in adulthood into a challenge where we have to straighten the penis and give them back the urethra. This again is a challenging fight and our surgery which we do it. So friends, aims are to achieve beyond the sex part. Aims are to achieve what it is. And my colleagues, senior colleagues in this audience know that today's erectile dysfunction is not about the penis. If you don't get a good erection, your heart is moving in the wrong direction, is about a metabolic syndrome. That means there are so many diseases which actually bring about structural and functional changes in the organ, in the arteries, in the veins, in the capabilities around. And therefore, the lifestyle risk factors can bring about changes in the penis, as a result of which we'll land up with a metabolic syndrome which actually messes you completely. So my colleagues in diabetology, in endocrinology, all look into it and look at that. We get them sorted out completely. I must not miss out diabetes, which has been talked so strongly from this file. Diabetes is an amazing kind of comorbidity where a lot of end organs, the retinas, the nephropathies, the bladder cystopathies, and end-stage penile disease happens around. So in this situation, the onset of diabetes mellitus is actually very aggressive. There's a huge stage migration. There are billions of work and paper happen around where they talk about diabetes people require more aggressive treatment. The Viagras will not help. Even 200 grams will not help. And they have a huge stage migration. They don't work with the first and second line therapies. In other words, ED and diabetes are common and costly health conditions and occur more frequently with advancing age. The present study talks about the assessment and differences in ED where men after diagnosis to oral therapy very quickly would progress and they would require aggressive treatment. So if you have diabetes of NIDDM and they have got erectile dysfunction, it already has gone deep into their situations around. And therefore, it is the rational approach is to look at and giving them probably a refractory erectile dysfunction aspect and treat them, because the shifts happen very dramatically. I will not go deep into it, only about the positioning of the time that we have. But these people require a therapy where you have to position yourself and reincarnate and probably give them a cure. Giving them medicines and giving them erection device does not work, which means the evidence today is on refractory erectile dysfunction, not treatable, to give them the man's thing called penile prosthesis. That I happen to be doing. I have to look at these kind of individuals whose nerves are damaged, vessels are damaged, they have got a urethral damage and had nothing to do with erections around the age as young as this, probably got a prosthesis and has the erection capable for himself and his partnership and his confidence. When we look at somebody who's diabetic and a refractory ED, men living in huge agony around, there's nothing which can work on them. And these kind of patients are microangiopathy, silent change, peripheral neuropathy, everything failing in their heart. These only require a penile prosthesis. So friends, when you look into all these patients around whose nerves, vessels, all are getting damaged, they deserve a therapy at that age group. I'm sure at 70s, 80s, we don't talk this. We talk about Parkinsonism, arthritis, and other aspects of cure around. So as I come to a close, looking at other aspects, I'll just close it with understanding that there's a huge subset of burden of these diseases in the society. They all see you as physicians. You are the first touch to my colleagues in urology, andrology in Kolkata, in Bengal urology. To demystify all these patients around, I think penile process is a requirement. Imagine somebody has got a very tight frenulum. When he performs sex, he has an emergency. He bleeds from the frenulum at night. He probably never performs sexually. This frenulum breve or the tight frenulum can just injure around. The last minute, please. And then there's something called as penile fracture. We never knew about this. A penis which is bent into the perineum in a patient with a woman on top who doesn't know sexually can actually fracture his penis, tear the tunica albuginea and mess it completely. So when we look into this, we are looking at impossible to possible, curing them. My last few pictorials are about adult men presenting with all this and demanding erectile capabilities. Imagine a complete extrophy epispadias. Imagine somebody who has got no penis, completely deficient or very small penis. Imagine somebody is epispadias or an extrophy repair. These are the people who suffer in agony. They have no choices. They probably look at everything every day. They probably request and help. So at the end of it, friends, as I come to a close, we live in an era of stress. The stress is so much internal for these innovations. We also live in an era of innovation. We are grading ourselves up with better and better medical therapies. We live in an era of competition, expectations of modern patient and evidence-based medicine only. It is time to set up this kind of a conglomerate where a physician and a urologist could look forward to the couples. I did not talk infertility, did not talk anything on the scrotum and torsion testis, which is another big problem around. But friends, as I come to a close looking into timelines, age, presentation, need and expectations are truly a challenge in all diseases that we deal every day. It was only to bring you in 31 minutes and 16 seconds that I took to make you wake up that phenomena of men is very agonizing. They go through it and treatment delays their lives lost. Thank you AAPONCON 2024 for the inaugural Congress. It feels good to be here in the morning time. Dr. Oza, thank you so much. Thank Dr. Sandeep, respected chief guest and colleagues in this audience. I respect you all for having given me an opportunity on this wonderful stage on the inaugural Congress. Thank you, chairpersons.
Thank you, Dr. Sanjay, about your lucid presentation of a problem. It reminds me when I attended a talk by Prakash Kothari 45 years back. That time also, when this topic was very least discussed, and Prakash Kothari narrated that it is duty of a physician to ask the question about the sexual problem of the patient, not the duty of the patient to tell about. And now I am happy that Sanjay has repeated the same advice, that it is our duty when we go for the history taking, we must ask him, and we should not be shy to ask, because that is the biggest problem which patient doesn't want to tell. Thank you, Sanjay. I think one or two questions, because it is such an important topic, so audience can ask. Thank you.
Sir, my one question is there. You talked about sildenafil and these 5 DP inhibitor, but now Eroxocom is available in USA without prescription. It is FDA approved drug. Have you used in India? Because it is still not available here.
So it will take some time to come. We have a drug called Avanafil. I am not sure. Yeah.
5D. But it is a locally applicable drug, just recently approved by the FDA.
Agree.
Sparingly available still. Have you used in your practice?
No, not yet. Not yet. Not used yet, but I know the drug is good. It'll come, it'll hit our shows very soon.
I tried in the USA also, they have shortage. I was just in John Hopkins few days back, but they told it will take at least 1 month.
Sir, how can we diagnose and treat venous leakage?
Yes, wonderful question. So I did not show you the slide where venous leakage before Rupin Shah and myself used to tie the veins. The era is gone. A venous leakage will only be treated by your penile processes. There's no way you can treat anything else because venous leakage cannot be treated. There was an era when we used to do a crime of tying all the veins. I've done that. I've done 17 patients around. A temporary result for a few months and then we are again villains around.
How can we stem the diagnosis?
Come again.
How can we diagnose?
Venous leakage.
Yeah.
The patient's erection goes off rapidly. So rapid due tumescence is the clinical picture and a penile Doppler will tell you the reality.
Clinical clue.
Clinical clue is a rapid due tumescence after a very good erection. He has a great erection and the thing drains off, rapid due tumescence. And you do a Doppler, you find the venous leakage. That's how it is. So you pick up from history and pick up from examination. Dr. Oza.
Yeah. Sir, there had been many combination which use the sildenafil as well as the paroxetine sort of a combination. And I have heard that the paroxetine-like molecule actually it worsens the quality of erection. So is it true? Then why there is a combination like this?
Wonderful. So India is a country where you can drive on the left and the right and the center kind of thing around. The combination in Jugaad is our own innovation. So the aspect of combining an erectile drug with a drug for rapid due tumescence, which is dapoxetine, is only allowed. That means paroxetine was a non-specific SSRI in the yesteryears, which we used because we never had a drug called dapoxetine. Dapoxetine is like sugar and paroxetine is like tulsi ka patta. So you will not, if you want sugar, you will not use tulsi ka patta, you will use chini and good. So using dapoxetine along with this is what it is. The Indian pharma companies produce whatever combination they want. We got to be very careful about what we give to the patient. Not necessarily it actually damages the erection. What happens is a huge mismatch. It's a non-specific drug. So much of SSRI central effects happen around, like it's about being drunk on alcohol and performing erection. So I think the balance is dapoxetine with tadalafil or with any of the drug, avanafil or the new drug or the age-old drug called sildenafil. Please don't use paroxetine as a first-line drug. It's a great drug. So sertraline, paroxetine are wonderful drugs as sustained release for refractory premature ejaculation.
I've got a fantastic presentation, really mesmerizing. So I've got one question. After having the penile prosthesis, is there any problem of body images?
No.
I know there are the advanced techniques by which you put the pumps inside the scrotum and all that. So because previously older versions were having the body image problems. So is there?
No. The malleables today, including the Shah's processes, are great malleables. You can hide it. The concealability and non-vulnerability about it getting injured is very good around. So you can conceal it so well. And people learn to accept it. It's all about, you know, I'm a boy. I had a penis, I was happy about it. And then I had a penis which could get erection, I was happy about it. Imagine I do a new phallus, I create a new penis for it. It's something which has been given immediately to the body. So people have to imbibe it. And that's where your and my job is to counsel. Counseling is not a one-stage job. You got to counsel multiple times. You got to break the ice in any diseases around. That's how it is.
Yeah. Thank you.
Thanks.
Sir, contraindications of sildenafil and interactions with other drugs.
Sildenafil.
Yeah.
Interactions with either drug.
Interactions and contraindications of sildenafil.
Contraindication could be the susceptibility of hypersensitivity, number one. Number two, obviously all patients who are on a drug which could cause their cardiac issues is about the glyceryl trianitrate being on there. You can't give them around. Patients can otherwise take it around. Interactions with the alpha blockers was worrying at that point. Now they says that you can still use within 2 hours of this. So no major interaction. You got to be very careful. Talk to your cardiologist. He is not on glyceryl trianitrate and I think you can use it very well. Start with a small dose of 50 milligram. The way is induction and then a maintenance. Don't give one tablet. Jab perform karoge tab loge, kaam nahi aayega. It has to be induced and then later on taken to the next step.
Okay, thank you.
Yeah.